Very good morning to all EPs, fellow colleagues, and all the audience. Today I'm going to present about euglycemic DKA. Introduction. Euglycemic DKA is a clinical syndrome occur both in type 1 and type 2 DM, characterized by blood glucose level less than 11 with severe metabolic acidosis, PA 7.3, 15, and is associated with ketonuria or ketonemia. So the etiologies are starvation, for example, fasting, anorexia, use of ketogenic diet or alcohol use, pregnancy, pancreatitis, glycogen storage disorder, surgery, infection, liver cirrhosis, insulin pump use, SGLT2 inhibitors, and trauma. The physiology. Carbohydrate deficit results in decrease in serum insulin and excess counter-regulatory hormones like glucagon, epinephrine, and cortisol. The increase of glucagon and insulin ratio leads to increase in lipolysis, increased free fatty acids, and ketoacidosis. So ketone body production in euglycemic DKA is similar to DKA. So resulting in anion gap metabolic acidosis, which triggers respiratory compensation, which is sensation of dyspnea, and as well as nausea, anorexia, and vomiting. So volume depletion resulting from the decreased oral intake, vomiting, and osmotic diuresis from the glucosuria, and further exacerbation from the elevation of glucagon, cortisol, and epinephrine, worsen the lipolysis and ketogenesis. So additionally, for also decrease in gluconeogenesis by the liver occur in fasting, where hepatic glycogen is already depleted, and also increase glucosuria by the kidneys also causes euglycemic DKA. So this is SGLT2 inhibitors. The newer form of class of anti-diabetic drug that increase risk of euglycemic DKA. The mechanism of action is enhance excretion and block reabsorption of filtered glucose from proximal convoluted tubers, and also stimulate the release of glucagon from the pancreas. Also suppresses the removal of ketone bodies by the kidney. Etiology is pregnancy. Pregnancy is physiological state of hypoinsulinemia and also increased starvation. Increased level of cortisol and placental lactogen, insulin resistance, and also episode of vomiting and fasting can lead to exacerbation of starvation ketosis, and also respiratory alkalosis leading to bicarbonate loss in urine and exacerbate more acidosis in pregnancy. Next etiology is alcoholic. Excessive alcoholic consumption in a person with diabetes can destroy pancreatic beta cells, decrease gluconeogenesis, and also decrease glycogen storage. Coupled with the vomiting, carbohydrate starvation can accelerate the lipolysis and ketoacidosis in euglycemic DKA. So this is from history taking and physical examination. What we can find from the euglycemic patients are may or may not present with polydipsia, polyuria. Next is nausea, vomiting, generalized malaise, lethargy, loss of appetite, and abdominal pain. The onset may be insidious compared to hyperglycemic DKA due to mechanism of subacute starvation, which required to induce ketosis and dehydration. Next is we have to find the inciting infection or stressors pregnancy, surgery, pancreatitis, alcohol use, and fasting. So patient will come with rapid breathing, known as small breathing, which represent respiratory compensation of severe metabolic acidosis. They may have a fruity odor of breath due to loss of acetone. Patient will come with tachycardia, hypotension, altered mental status, and delayed capillary refill if there is a sign of total body fluid losses. In severe cases, patient will come with severe dehydration, metabolic derangement, which can lead to hypovolemic shock, lethargy, respiratory failure, coma, and can cause death also. So laboratory evaluations for Euglycaemic DKA includes basic electrolytes, glucose, RP, which is urea creatinine electrolytes, urine ketones, serum ketones, and blood gases such as ABG and VBG and lactic acids. For imaging, normally we have to do chest X-ray and ECG, urine examination, urine FEME, to look for ketones, and to rule out the causes of UDKA. So we have to check for full blood count and also send blood culture, count for anion gap, serum osmolality, send to rule out any toxic alcohol ingestion. Patient suspected with severe and unexplained anion gap metabolic acidosis. Next is
Kamini,
taste.
just previous slide.
Any other?
Previous slide.
For this.
Tak, previous slide yang tadi, yang merah tadi. Toxic alcohol tu nak hantar ke mana? Is it something that we offer?
Sini kita tak ada.
So just supaya tak ada orang termislead pening nak cari dalam e-his ke mana nak send toxic alcohol ke kat Malaysia or at least dekat Malaysia lah. Most hospital tak buat tau alcohol level. It's not a routine test. Kita tak ada there's no way for us lah, tak ada apa, bukan macam PCM kita boleh hantar TDM for alcohol, tak ada. So it's something that you have to expect lah or suspect when patient have unexplained high anion gap metabolic acidosis. You need to consider, usually based on history sahaja. There's no real way to confirm. Even masa kita bila ada ethanol dengan methanol punya poisoning punya outbreak pun, the sample pun is sent somewhere else and take, weeks to come back. So by that time, you can't really wait for the test result to initiate treatment. Just to clear this up lah. Alkohol ni kan semua orang sibuk nak hantar blood for alcohol apa semua. And then tu pun dah cukup pening kan. Polis pun datang ke hospital nak blood for alcohol lah apa semua. We don't do that. Okay? Okay, carry on.
Potassium level will vary but great attention should be paid to the level before starting therapy as total body potassium can be seen in patient with poor intake, and mild hyponatremia may also be seen compared to pseudo hyponatremia seen in profound hypoglycemic state. Treatment or management basically fluid resuscitation, sama macam DKA, continuous insulin infusion. Yang beza dia just in contrast with DKA management is sebab glucose dia less than 11, we start dextrose 5 and also dextrose 5 or dextrose 10 lah. Other management sama macam DKA. Add-on potassium supplement semua same like DKA lah.
Okay, this one everybody needs to be clear. Kalau you dah start to diagnose Euglycaemic DKA, of course lah, macam DKA biasa-biasa, fluid resuscitation is always the first thing. Insulin infusion still kena start. In patient with Euglycaemic DKA, sugar 4, sugar 5, sugar 7, 8, euglycemia kan. You still need to start insulin infusion. Okay, tapi kita start insulin infusion tu along with D5 infusion. Macam DKA yang sugar dia dah fall below 15.
Fall
Kan?
below 12 tu.
Patient yang sugar dah fall below 15, 12 or whatever tu, kita tak stop the insulin. Why insulin is important? Because the mechanism is the same. It's still absence of insulin. Cuma sugar dia normal. So absence of insulin. So the absence of insulin tu yang lead to ketosis, production of ketone. So insulin needs to be there to stop ketone punya production and subsequently improve the acidosis dan sebagainya. So if you start to suspect patient yang ada Euglycaemic DKA, you still need to start insulin infusion. Takut Euglycaemic DKA tapi tak start insulin because sugar is normal. Or you start insulin, orang datang attack you, you tak boleh nak defend. Kenapa you nak start insulin? Kan? Kita pun macam biasalah. Bila my medical primary team datang bising-bising, kita ikut primary team. Kan? So you need to know why we start insulin infusion, especially those yang adik-adik muda remaja yang masih terapung-apung ni, you need to know why. In DKA, insulin infusion kena start juga despite sugar being normal. Okay, carry on.
Then blood glucose level should be checked hourly and electrolytes for hourly as standard like DKA lah. And patient on SGLT2 inhibitors should discontinue the medication.
Apa
and
contoh
also
SGLT2 inhibitors ni? Nama glamour dia lah. I mean nama ni bunyi macam LGBT je. So Aisyah susah juga nak sebut. Contoh. So tu empagliflozin, canagliflozin, dapagliflozin. These are drugs yang masa zaman saya medical student dengan houseman tak wujud lah. Okay. These are drugs that's fairly new in the last 5 or 6 years, at least kat Malaysia. And a lot of especially lah endocrinologists or diabetologists start all these ubat. Tapi it's a drug that increase risk of Euglycaemic DKA. So this is where your drug history is also important. Kenapa perlu tengok apa drug patient punya previous drug? Sebab it might trigger why patient datang dengan acidosis dan sebagainya. So apart from metformin, sulfonylureas, you need to ingat juga nama-nama ubat baru.
Pula the sodium glucose co-transporter inhibitor.
Yeah. SGLT2 inhibitors. Macam yalah LGBT ya, I ingat LGBT ya. So anyway, so carry on.
Okay, sodium bicarb infusion are not indicated even if in the setting of severe acidemia where the pH is less than 6.9. It's still controversial. IV fluid resuscitation should continue until the anion gap closes and acidosis has resolved. Next, differential diagnosis. In patient who present with anion gap metabolic acidosis, we have to consider other differential diagnosis such as infection, pneumonia, UTI, bacteremia. Patient presenting with abdominal pain have to consider any intra-abdominal infections or pancreatitis. And then also consider toxic alcohol like methanol and ethylene glycol, salicylate overdose, lactic acidosis, starvation ketosis, and also pregnancy itself. And also and also other causes like newly administered insulin also can cause the euglycemic presentation lah. Prognosis: most of the patient with euglycemic DKA recover well with prompt recognition and treatment. Delayed diagnosis and inadequate treatment, especially involving hydration without dextrose or insulin infusion, can lead to persistent acidosis, vomiting, and prolonged hospitalization. Prognosis is worse for small children. Cases with respiratory failure, hypovolemic shock, coma, and death. Death is rare in euglycemic DKA. However, pregnant women are at the greater mortality risk than general population. The complications of euglycemic DKA can result in persistent vomiting, dehydration, hypoglycemia, hypovolemic shock, respiratory failure, cerebral edema, coma, seizure, infection, thrombosis, and myocardial infarction, and also death. Maternal euglycemic DKA can increase the rate of fetal and mortality. Consultations: consider consulting NS critical care interventists and also endocrinologists for severe cases. And for pregnant women suffering with euglycemic DKA, consult with obstetrics and maternal fetal medicine consultants.
Okay, so yang consider consultation ni for medical lah. Kita refer medical lah. They the one who's supposed to consult endocrinologist, whatever, critical care, apa semua. So, I mean, you nak call endocrinologist yourself pun boleh. Tapi usually in the acute phase tu, usually tak adalah necessary sangat because the management is pretty standard macam DKA biasa. Okay, carry on.
SOPers and other issues. Successful diagnosis is depend on the early screening with serum or urine ketones. Even the serum glucose is normal whenever the euglycemic DKA is suspected. Besides volume expansion with crystalloids, the foundation of therapy is combination of dextrose 5% or 10% and insulin infusion until the acidosis resolves. Insulin infusion should not be avoided due to normal glucose lah, yang ni macam Dr. Fairuz bagi kita tadi. And ketosis does not resolve with just the intravenous crystalloids hydration alone lah. And sodium bicarb infusion is not indicated. SGLT2 inhibitors punya treatment have to be discontinued lah as soon as euglycemic DKA is diagnosed.
Okay, so basically these are one of the important slides lah. If tak ingat apa-apa pun ingat this slide lah. So euglycemic DKA is very much a diagnosis you make bila you suspect. If you don't think about euglycemic DKA, memang you tak akan make diagnosis euglycemic DKA. So one of the criteria, one of the thing that you when you need to suspect euglycemic DKA is one, your patient ada unexplained high anion gap metabolic acidosis. Two, ada presence of serum and urine ketone. So at least semua patient with metabolic acidosis or ada high anion gap metabolic acidosis, you need to do at least urine ketone lah. So if this patient ada unexplained high anion gap metabolic acidosis and ada presence of urine ketone, you need to consider euglycemic DKA, especially if the acidosis tu tak improve with fluid resuscitation. Sebab biasa kita akan bagi 1 liter or 2 liters, and if you tengok the acidosis tu macam tak berganjak langsung, then you really need to consider euglycemic DKA. And euglycemic DKA ni is a diagnosis that everybody likes to talk about. Tapi to commit yourself, this is euglycemic DKA and I want to start insulin infusion in patient with blood sugar of 5 takes willpower, because the nurses akan tengok you, betul ke doktor? MA pun tengok you, medical pun tengok you, semua dah tengok you. Betul ke nak start insulin ni? Patient DXT 5 ni. So you need to be able to justify to yourself why you think of euglycemic DKA lah. And itulah, dan like any other DKAs, sodium bicarb infusion is always not indicated lah. Tapi everybody always go to sodium bicarb. Tapi no, it's not. Sodium bicarb infusion is not indicated. It's not the treatment lah, because you're not treating the underlying cause of DKA. So sodium bicarb DKA ni, you need to stop the ketosis, the ketone production tu. Baru the acidosis will improve. And if the acidosis tak improve juga with fluids, insulin dan sebagainya, you really need to be thinking about other reason why patient might be acidosis. Takut ada external acids. Manalah tahu sambil-sambil DKA makan aspirin overdose ke, or ada AKI ke, or dan sebagainya. Okay. So management is quite similar to DKA biasa je. Tapi the thing is, the main thing about euglycemic DKA is bila you suspect. Because selagi you tak suspect and tak think about euglycemic DKA, you're not gonna start treatment. And then you wonder why patient tak improve despite adequate, or sampai dah overload dah bagi fluid kan. The acidosis still persistent. And like another slide yang Kamini mentioned before, always look for precipitants of DKA, be it euglycemic or DKA biasa. You know, buka selimut, check celah jari kaki, check belakang peha, belakang betis. Because sometimes patient datang dengan DKA, especially kalau dah bawa dari rumah dah ada selimut kan. So, treat lah, jumpa pula DKA, treat lah DKA. Tapi buka je selimut, sebenarnya ada, you know, cellulitis ke apa semua yang tidak kita perasan sebab kita tak selak betul-betul. 90% of the time, DKA is always precipitated by infection. So you really have to look hard for infection. Chest X-ray, urine CNS, blood CNS, and you know, just examine for bisul-bisul or apa-apa yang tersembunyi. Dan malulah kan, treat DKA, selimut tak buka, rupanya dah ada gangrene kat kaki. Kan? It's embarrassing lah kan. Okay, I tak ada apa nak cakap dah. Kakak Vila nak tambah apa-apa?
I think thank you so much Dr. Hairus for covering me. I had ED just now zone tadi. Thank you. I think what Dr. Hairus said, he covered most of the topic, and very good Dr. Kamini for the presentation. Saya sempat masuk separuh je. Okay, I think
very thorough ni. And I think I like the initial slide yang Kamini summarize what happens in DKA. So it's a good slide for macam kalau housemates, good slides for houseman nak baca, just a quick summary what the metabolic changes dalam DKA. It's quite a good slide.
Good job Kamini. Okay. Thank you Dr. Kamini. Good effort.
Ada lagi tu.
Habis debat hal. Sorry.
Take over I'll take over.
Saya nak sambung charger je.
Boleh Kamini?
Okay. So enhancing healthcare team outcome is early diagnosis and initiation of treatment that significantly improve the morbidity and mortality of euglycemic DKA. In patients presenting with euglycemic anion gap acidosis, great care must be taken to rule out other causes, including sepsis, toxic alcohol ingestion, and etc. Early IV crystalloid and prompt initiation of insulin and treatment requires a team of interprofessional healthcare workers like physician, critical care interventists, endocrinologists, nurses, and pharmacists to achieve better patient's outcome. Case discussion.
Can.
Okay. 21 years old female underlying type 1 DM on insulin presented with lethargic for 2 days, poor oral intake for 2 days, and defaulted insulin for 2 days. Otherwise, no fever, no URTI symptoms, no UTI symptoms, no nausea or vomiting. On examination, patient alert conscious, dehydrated, looks tachypneic, vital signs, BP 110, 78, rate 110, temperature 37, SpO 200, DXT 4.5, with ABGs, pH 7.1, bicarb 6.1, anion gap 22, and urine FEME got ketones 2+, and glucose 3+. For the blood investigation, the total white platelet all normal, RP, potassium 2.6, PF14 and creatinine 200. This is the case discussion I took from internet lah. This patient diagnosis is
Ada siapa nak try tak?
Sebab tajuk Euglycaemic DKA, my diagnosis is Euglycaemic DKA.
yeah. So euglycemic DKA, this patient.
But why?
Why?
Tajuk dah give away the diagnosis lah. Okay. So but I think it's I think no discussion lah kan. It's very clear cut lah. This is we suspect Euglycaemic DKA in this patient. Tapi the more important thing is why dia dapat Euglycaemic DKA. That's probably the more important. I mean, because kalau you bagi budak darjah 1 dengan lecture ni pun dia akan cakap Euglycaemic DKA. Because it's very obvious. Tapi the more important thing is why dia dapat Euglycaemic DKA. Because treating the underlying cause is actually the how you improve the patient lah. Kan, setakat treat DKA tu you tak selesaikan lagi underlying cause. The DKA will keep going on until you actually selesaikan the underlying problem. Huh? Okay. Carry on.
This one is second case. 25 years old female with underlying DM type 1 presented dysuria, intermittent high-grade fever, chills, rigors, nauseated and poor intake. On examination, alert conscious, tachypneic, severely dehydrated. BP 100/67, pulse rate 112, temperature 38.5, SpO 200 and DXT 5.7. Upper abdomen noted got mild tenderness over the suprapubic region, renal punch negative, and also urine FME got leukocyte, ketone 3+ and nitrite positive. So this is a blood investigation. Total white cell 17. RP 3.7, urea 10, creatinine 179, PBT, PHP 7.03, bicarb 6.7, and ion gap is 26.
Iwan ada ke? Iwan baru float kat kita kan, seminggu 2 minggu. Iwan ada ke?
Ada doktor.
Ada. So anion gap 26, high ke, low ke, medium ke, acceptable ke?
Saya tengok asal.
The anion gap tu, is it high? Low?
Nak kira.
Dah ada dah anion gap tu, tak payah kira dah.
Oh, okay.
Dia 26 anion gap dia. Is it high? Low? Ada 3 lah jawapan you. Normal, high or low. 30% chance each.
High.
Huh? High. Excellent. So what's the normal anion gap? So that everybody's clear lah. Sebab kami ni duk cakap high anion gap, assuming that everybody knows what's the normal anion gap kan. So what's the normal anion gap? Lebih kurang lah.
3 to 10.
3 to 10. Boleh lah. It's around, I would think around 12 lah. Anything more than 12 is high anion gap lah. Tapi it depends on which book that you read lah sebenarnya. Tapi you need to know anything more than 12 is high lah. Okay. So, okay. Kita dah bully Ewan. Siapa lagi yang kita nampak macam ada ni? Afif Noha ada? Afif Noha.
Ada doktor.
Macam mana nak kira anion gap lah?
Formula.
Apa, buka smartphone pun orang tak nampak.
Plasma sodium minus chloride plus bicarb.
Okay, so all the positive ions minus the negative ions, and then you get the anion gap lah. So the positive ions is sodium, and the negative ions are chloride and bicarb lah. Kalau ikut yang lama punya, dia tambah potassium. Tapi usually dalam konteks value tu, potassium tu tak mengganggu sangat lah, because you know sodium tu ratus-ratus kan, 100 lebih. Chloride pun 90. Bicarb pun usually lebih pada 10. And potassium ni kadang-kadang 3, kadang-kadang 4, kadang-kadang 5 at most. So dia tak kacau sangat the value lah. Tapi of course kalau you ada pakai formula yang ada potassium, the anion gap tu dia akan lari sikit lah. Mungkin yang you cakap 3, 10 tu yang pakai potassium. Yang 12 ni yang tak pakai potassium lah. Tapi nowadays the trend is everybody just ignore the potassium lah. Just sodium minus bicarb campur chloride. Okay, so it's important thing to kira lah. Okay, because sometimes you nampak ABG tu nampak macam normal, tapi sebenarnya if you kira anion gap, it's actually high anion gap. Sebab kadang-kadang patient may have acidosis and alkalosis going on at the same time. So it masks the high anion gap tu. So always kira anion gap when tengok patient with ada acidosis dan sebagainya. Okay, carry on. Bagus. Bukan ada orang lah di sebalik gambar-gambar ni, ingat ke gambar sahaja. Excellent. Okay, teruskan.
The diagnosis is Euglycaemic DKA precipitated by UTI lah. So this is my reference, CPG Management of DM tahun 2020, and also other internet punya articles lah.
So satu lagi just nak highlight, management of DKA ni, the most important part of DKA management is actually monitoring. Because management lain pretty basic je, bagi fluid, bagi insulin, bagi antibiotics, ada. Tapi where we fail the most or where we could improve more lah is the monitoring part. Monitoring urine output. Sebab korang perasan tak, bila tanya fluid berapa banyak nak masuk, saya dah bagi 3 liter kat patient ni doktor, tapi acidosis tak improve. The next question is, yang keluar berapa? Keluar 4 liter, dia kencing 4 liter. So maksudnya patient tu masih negative balance. That's why the acidosis don't improve. So you kena, walaupun you rasa dah masukkan 3 liter, tapi you kena tengok juga dengan dia punya urine output. Because you nak kejar, usually patient with DKA ni dia ada deficit around 5 liters. Sebab dah berhari-hari dehydrated kan. So you nak kejar deficit tu, you start lah DKA regime 1 liter 1 hour kan. Lepas tu you repeat ABG. Tapi you tak, kadang-kadang kita tak take into account the urine output. And bila kira balance, patient sebenarnya negative balance lagi. That's why the acidosis dia tak improve. Kan, dia keluar lagi banyak yang masuk. So patient still in deficit. So monitoring tu, monitor urine output, monitor sugar, the monitoring part tu yang selalu we can improve more lah. DKA ni is not something that boleh treat and tinggal main phone. Usually kena selalu review. And as MO apa semua, to make sure that you appear macam you review, you kena sentiasa document lah your review. Bukan nak kena tulis panjang-panjang. Every time you review, tulis lah. Review after 1 hour, sugar sekian-sekian, urine output sekian-sekian. Tak perlu dah nak copy and paste everything that you written before. It's just that nampak you review, dan baru nampak macam buat kerja lah. Kan? Ni sebab bila jadi apa-apa, masuk audit, nampak review sekali masa datang, patient 3 hari kat sini dan tak review dah. Sedangkan kita tahu korang review, korang buat kerja, cuma tak tulis je. Tapi bila tak tulis tu, nampak macam tak buat lah. Ini also pengajaran untuk adik-adik lah, anak-anak yang floating ni lah. Dah tua dah saya sebenarnya. So
anak dah Dr. Virus.
Itulah. So begitulah. Okay, saya tak ada apa nak cakap.
Okay, thank you. I think the virus covered well for me today lah. I'm really full of the virus. Okay, can we second presenter? Thank you very much.
Thank you.
Doctor, sorry,
Yeah.
I would like to ask a question.
Yeah.
Please.
If a patient DKA but underlying CKD or ESRF, how are we going to control for the fluid?
Okay. In general, we know the DKA pathology itself, it will cause significant dehydration, right? Okay, so we have certain tools, especially we have our ultrasound in our ED, right?
Yeah.
So we can use ultrasound to identify the status of patient's fluid. So we see what is the status of the patient's fluid status by the IVC, is it collapsible or not, and how much the patient can tolerate the fluid. So initial one is status of fluid. Second evaluation is fluid tolerance level. So how you're going to evaluate the tolerance level? Looking at the patient's lung. So look whether, because first thing kalau kita overload, the first extravascular space fluid will be yellow. So see whether there is any B line in the lung. Third, look at the contractility of the heart. So lepas kita assess tiga-tiga ni, we can accommodate our fluid level to the patient lah. But clearly we can't give the total 6 pint or the total bolus how we manage our normal healthy patient. So we need to accommodate the fluid requirement in this group of patient according to the patient's body need. Okay. Mungkin bolus we can give, let's say the patient BP is 90/60 upon presentation and you want to give a bolus for the patient. So selalunya kita bagi 10 to 20 ml per kg kan? The bolus. So in this group of patient you can reduce 5 to 10. So there's other space for you. If at all you need to repeat the bolus, you have another 5 to 10 ml. Then reassess the patient. As Dr. Fairuz mentioned, this group of patient and this diagnosis of these few diagnoses require very, very close monitoring. Frequent and close monitoring. So you need to evaluate. Ada uric output ke tak ada? Okay, let's say that patient is going due for HD for the patient for that day. Okay, you still have a good space of fluid management for this patient lah. So you tak payahlah takut-takut nak bagi banyak fluid, tak apa lagi. Okay, if you manage to stabilize the patient and BP all become normalized, you can due the patient to HD as early as possible kan? So tapi in general you cannot accommodate this patient fluid tu seperti mana you treat as a normal individual lah. That is the first rule. Second rule, you have to taper your fluid according to patient's status by assessing, looking at the ultrasound, fluid, IVC, lungs, and also heart contractility. Okay?
Yes. Okay. Thank you very much, Doctor.
Good.
Okay, dalam nak tambah lah. So dalam your review tu, dalam your review tu, itu benda-benda yang nak kena tulis macam tu lah. Dengan lungs still clear. You know berapa, bukan nak tulis panjang-panjang pun, just to show that as long bila you keep giving fluid, you keep assessing the patient. You make sure that the patient is not overloaded dan sebagainya lah. Kan? So then orang tak boleh query you lah. Oh, ED lah ni bagi fluid vigorous sangat sampai patient overload. Something like that lah. Okay. So and DKA ni, it's always easy to just follow DKA regime lah. After 1 liter 1 hour, 1 liter 2 hours dan sebagainya. Tapi it doesn't apply to all patient. You still have to reassess. Sebab sometimes tak semua patient respond cepat. Sometimes you tak kejar dengan cepat lah patient tu.
Any more question? Okay. Then we call that as one section. Thank you, Dr. Kamini.
Thank you, everyone.
Okay.